So my talk today is actually about normal and abnormal second stage CTGs. I chose this topic because there have been a few medical legal cases, and we know that second stage CTGs are difficult to interpret. Now, early decelerations is very common in the second stage of labor, and we must know how to define the early decelerations. And if we take the decelerations and compare it with the contractions and draw a straight line from the beginning of the contraction to the end of the contraction, if the deceleration falls like a mirror image and is less than 40 beats from the baseline and has good baseline variability, then we assume that this is due to head compression. And if the baseline is steady with continued good baseline variability, that is nothing to worry about. So that's a normal second stage CTG pattern. Now, compared to this, these are not normal, these are late, because if you draw the same two lines from the beginning of the contraction to the end of the contraction, these decelerations come a little bit later, or take the acme of the contraction to the nadir of the deceleration, it's much later. So this you have to be very careful. And as you could see, the baseline variability is gradually getting less and less, and these are late decelerations. Now, if the decelerations have absent variability, that becomes very ominous and one has to treat. And this can happen in the first stage or second stage. So baseline variability is the key, even with late decelerations. If it is absent, you have to intervene. Now, the other common feature which is normal in the second stage is variable decelerations, but there's a different pattern to the variable decelerations. If you observe very carefully, the baseline rate is seen and it drops, but it stays at another rate for at least 1 minute or 60, 70 seconds before it goes up. And these decelerations are due to head compression, due to occipito-posterior position. If it is due to cord compression, there will be a shouldering of the deceleration followed by a V-shaped rather than a horizontal wedge here. So these are due to occipito-posterior positions, and you don't get much acidosis provided the baseline rate and the baseline variability is maintained. So this has been studied way back, and it has been shown that occipito-posterior position has variable decelerations, and there's nothing to worry about acidosis provided the baseline rate stays normal. Now, the ones which cord compression is more V-shaped, as you could see, it comes and immediately returns back to normal. And here again, in this case, there is nothing to worry. More likely it's due to cord compression. And the baseline rate being steady indicates there is no concern of hypoxia, because if the baby gets hypoxia, the baseline will go up, or if it is more acute, it'll come down. So these are cord compression decelerations, and the mother is pushing, as you can see the pushing spikes. You can observe as long as the variability is maintained and the decelerations don't change so much. Now, what do we mean by deceleration changing? If we take the first deceleration, if you draw a line from the initial onset of contraction to the offset, if the deceleration falls within these two lines, and if the duration of the deceleration is much less compared to the inter-deceleration interval, that baby will not get hypoxic. It is akin to immersing somebody under water for 30 seconds or 40 seconds and keeping the fellow on the surface of the water for 2-3 minutes. They can get rid of the carbon dioxide, get the oxygen, they'll be back to normal. If the heart is unable to cope and there is less oxygen to the heart, the deceleration will take some time to recover. So as time goes on, if you draw the same two lines, the decelerations are coming a little bit later. As you could see, it picks up a little bit later and it becomes more late to pick up. And as a result, the decelerations get more prolonged and more deeper, and the inter-deceleration interval gets shorter and shorter. So when the baby is at a short time at the surface, oxygenation is low, and if it is taking longer time below the baseline, then it is going to get hypoxic. At the same time, there's a baseline rate going up. That is due to catecholamine surge. That is not a good sign. And finally, the baseline variability will get reduced. So you can remember somebody swimming. And if they go down underwater for a short time but remain in the surface for a longer time, they are okay. But if they remain longer and longer underwater, then they are going to get hypoxic. And when you check their pulse, if it is high, that's not a good thing. So increase in the depth and duration of deceleration, decrease in the interdeceleration interval, which is not given in the guidelines, is quite important. So now we will look at the abnormal patterns. Abnormal patterns, there are 10 abnormal patterns. One is prolonged deceleration, which is obvious. The heart rate drops to below 80 and remains below 80. Second is prolonged deceleration, where the deceleration interval is much greater than the interdeceleration interval. And third is declining baseline rate with subsequent deceleration. So the baseline starts coming down, or alternatively, the baseline going up with each contraction, and doubling of the fetal heart rate. Sometimes you find two graphs, and one is at 75, one is at 150. That means there's a fetal bradycardia. Sometimes the fetus is dead, and the coinciding fetal heart rate, what we think is fetal heart rate got by ultrasound, is the same as what is got by the infrared pulse from the TOCO, the maternal heart rate. So we have to distinguish that. And recording of the maternal heart rate instead of the fetal heart rate, because the maternal heart rate accelerates in the second stage because of the uterine blood supply going into the maternal circulation, whereas the fetal heart rate should decelerate due to head compression. So the opposite happens. That means we are accidentally recording the maternal heart rate if you see accelerations in the second stage. Sometimes this switch can happen halfway through fetal and then maternal, and it can be intermingled. And poor recording of the fetal heart rate can give rise to poor outcome and also saltatory, which is increased baseline variability. So I'm going to show you some examples. This is prolonged deceleration, and can cause acute hypoxia. This can be due to occult cord compression or loop of nuchal cord getting tight, or there are 3 or 4 cords around the neck and getting tight. Alternatively, it can be due to abruption or scar rupture or unknown. Here you have to intervene by 3, 6, 9, 12 minutes guide. So by 15 minutes, if it doesn't show signs of recovery, then the baby should be delivered. And of course, in the second stage, you can do a forceps or a vacuum delivery. The second pattern I mentioned is subacute pattern. As you could see, there must be some nuchal cord around, and initially there are small decelerations, but it becomes much deeper and wider, and the interdeceleration interval gets shorter and shorter, and the variability becomes saltatory. And here the pH can drop by 0.01 every 2 to 3 minutes. And once the baseline rate starts dropping, it'll be a bradycardia. So here the baseline rate is kept steady, and intervention should take place, thinking within 20 to 30 minutes you have to deliver this baby, because the drop of pH is 0.01 every 2 minutes. So here nothing has been done, and towards the end of this race, as you could see, the baseline rate drops and it becomes bradycardic. And 10 minutes after bradycardia, forceps was done. But the pH is 6.79 and the base excess is -19. So they said baby had the prolonged partial hypoxia, and the terminal bradycardia causes profound acute hypoxia. So it has quadriplegia, and thalamic hypothalamic injury gives rise to hypertonic cerebral palsy. The third pattern you have to be careful is if you get absent variability with a steady baseline, it is going to decline. The moment you see the first decline of the baseline from 160 to 150, you must take action, because the heart is going to fail otherwise. So if it is left alone for 10 minutes, it is dropping 150 to 140. And if it is continued, it drops to 130, 120, 110, 80, and so on. So once it is on the sloping decline line, then you can't resuscitate this baby so well. And this was a stillbirth. So declining baseline rate with deceleration is not a good thing. Increase in baseline rate also can give rise to acidosis. And here the baseline rate is 140 with decelerations, and they are broader. And as time goes on, it becomes 160. The baseline has risen up due to catecholamine surge. And here it has gone even beyond 160 to 170, and the decelerations are get much prolonged. Fortunately, she is fully dilated and she is likely to deliver. And she has been recorded with the ECG as well. And the ECG shows changes only towards the end of it. And at delivery, the baby had a pH of 7.05, which is not acidotic, and ABGA 9, its pH is on the low side, but it did very well. But if it continued, it would have been acidotic and delivery should have been undertaken. Because if you don't undertake the delivery when the heart rate goes up and up and up, then suddenly there could be a bradycardia. So once it is going up and up and up, you have to think, unless she's going to deliver within a short time, you have to assist the delivery. Doubling of the fetal heart rate can happen, and usually it is due to overstimulation with oxytocin. She's already on oxytocin, and in the late first stage, second stage, there is a reflex release of oxytocin called Ferguson reflex, and that causes too many contractions, as you could see from the baseline. That causes bradycardia, and the lower baseline is about 75, and it doubles up as 150. So the doctor thinks the upper one is the fetal and the lower one is the maternal, but both are fetal. The fetal bradycardia, which doubles up, that is due to what electronic window phenomenon of the machine. And since they didn't recognize that, when they delivered, the baby was severely acidotic, with ended up with convulsions. Now, this can happen, recording of the maternal heart rate, by two devices. The ultrasound picks up the maternal pulse, which is seen as a light drawing there, and the dark drawing is due to a tocotransducer with infrared picking up the maternal pulse, and the baby is dead. So this was going, and people thought this is nothing to worry about because it is picking up the maternal and fetal. The fetal, of course, with the second stage, with these large contractions, should show definitive head compression deceleration. The fact that decelerations are not present and both for coinciding heart rate, one should have recognized that the baby is dead and the machine is picking up the maternal heart rate from both infrared and ultrasound transducers. The next is misinterpretation of the maternal heart rate as fetal, because I mentioned with the second stage contractions, the blood gushes into the circulation and there is a rise in the maternal heart rate. So here's a 32-year-old gravida 1, 41 weeks. She has pyrexia, was treated with antibiotics. And as you could see, the trace is at 140. And they said vaginal examination fully dilated here, but they readjust the transducer because the contractions and the CTG heart rate is not recorded well. And when they readjusted, the heart rate is different. This is 140, it became 120. And with the contractions, if we draw two lines, the same time of the contraction, the heart rate is going up. So this is maternal heart rate. And people thought this was a reactive baby with a good fetal heart rate. As you could see, every single contraction, the maternal heart rate is going up. The fetus has a bradycardia. And when it got delivered, it was an unexpected outcome with an outcome of 0 at birth, 0 at 1 minute, 2 at 5 minutes, and 5 at 10 minutes. So this is because of the misinterpretation. This has been studied experimentally by putting maternal ECG electrodes on the mother's chest. And this shows that every time the mother contracts, there's an increase in the maternal heart rate, as you could see here, with good variability like that of the fetus. And once the baby is delivered, then the maternal heart rate becomes quiet because the uterus goes into sustained contraction. So those elevations are not there. Many times we deliver babies, and baby has come out, but the machine continues to give the noise, tuck, 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 and that is because it's on the maternal pulse. Now, this change can happen suddenly. As you could see, these are decelerations due to head compression. And at this particular point, there has been a bradycardia of the fetal heart rate, and the ultrasound transducer picks up the maternal heart rate because we know it coincides with the contractions. Every contraction, the maternal heart rate is accelerating. That means it is a mistake we have made by thinking it is fetal, but that is maternal because fetal should decelerate with head compression. Now, poor quality of the fetal heart rate in the second stage is a common phenomenon. And if it is so, you have to really use a scalp electrode or listen if the machine is not working properly. And if it doesn't rectify the problem of adjusting the transducer, it's best to listen and write because listening gives you a more reliable indicator rather than an abnormal transducer recording. So this is not a good quality trace. You don't know what you're really looking at. And here, interrupted, it is much better to listen soon after a contraction because you would have picked up the deceleration. So this is most likely due to hyperstimulation because the contractions are causing repeated decelerations. Even at this stage, no action was taken because they thought the baby is going to be delivered. But as you could see, this is like a subacute hypoxic pattern with deceleration lasting for a longer time than the time at the baseline. And the outcome was poor. And there are people who have studied second stage traces, and the conclusion is actually the occurrence of unclassifiable findings seems significantly more common among acidemic fetus. So if you can't read the CTG trace, better to auscultate and listen for the deceleration. And finally, the saltatory pattern. Saltatory pattern is a result of acute hypoxia happening before that event. So this lady had an epidural and late first stage and second stage of labor. She was bending down, the head goes and compresses the pelvic vessels, the uterine vessels. Nobody was monitoring the heart rate. And when she finished the epidural, they straightened up and put the trace on. This was the trace. This is a saltatory pattern, and usually the acute hypoxia resolving, it should become better in 10 minutes, maximum 25 minutes. And here we can say nearly 5 minutes, 15 minutes, 25 minutes, it doesn't change. So this can suddenly become worse. And as they observe, it is becoming bradycardic. So they decided to do a forceps delivery because of she was OP and fully dilated, but it was a little bit high. So ended up in a cesarean section, but poor condition of the baby and a poor outcome with the neonatal death. So in concluding, we have normal and abnormal second stage CTGs, and you have to think about prolonged decelerations where you had to deliver within 15, 20 minutes. Subacute hypoxic pattern where the deceleration lasts for longer than at the baseline rate. So where you have to deliver by 20 to 40 minutes. And when there is decelerations, you have to look at the baseline, whether it's declining or rising. Both are not good signs. Declining is worse compared to rising. And if in the second stage, if there is two heart rates seen, maybe we are hyperstimulating and we have to think about stopping the oxytocin and trying to give some tocolytic. And you have to be aware that the fetal heart rate and maternal heart rate might coincide with each other if the fetal has a bradycardia or a fetal heart rate is absent. And recording of the maternal heart rate instead of fetal heart rate shows accelerated trace in the second stage. And this switch can take place halfway through. And in the second stage, you must expect head deceleration, head compression decelerations. And poor recording of the fetal heart rate is the worst out of the lot. And when there is a poor recording by the ultrasound transducer, either you have to convert to a scalp electrode or use a stethoscope to find out. And saltatory pattern, you have to take action as soon as possible. Otherwise, the baby will get acidotic and be born in a poor condition. So in the second stage, more compromise occurs compared to the first stage. You have more because the contractions are much stronger, much longer in duration because of the Ferguson reflex and reflex release of oxytocin. And there's a good possibility of cord around the neck and cord compression. And this should be useful to know when to intervene. And when to intervene is when the decelerations get broader and deeper, and the heart rate goes up or down, or if the interdeceleration interval starts going down. Thank you very much for your kind listening.
Rubina ma'am, please unmute yourself.
Thank you for letting me know. So, sir, thank you very much for an excellent presentation. And I was saying that it was, as usual, very beautifully delivered. And I think the most important part of this presentation is that how can trainees hang on to each word that you said and make good use of CTG in labor? Because second stage of labor is a time where things can go wrong very, very quickly. So I think it is very important that CTG interpretation in the second stage of labor is accurate. I was recently at the ACOG conference, and on the three topics in which artificial intelligence was discussed, one of the topics was CTG and the role that CTG can play and artificial intelligence can play in interpreting the CTG patterns. But I wonder how efficient it would be because of the changing dynamics of the fetus and the pH and the intrauterine environment for the baby. But it is an area on which we should keep a close eye so as to see how much help artificial intelligence will do. But while artificial intelligence is developing, we have a real intelligence with us. And I think Professor Yusuf Latif is also here, and I would like to welcome him. And I would ask for him to comment on the presentation. Dr. Yusuf, sir.
Thank you, Dr. Veena. And sir, it was always a pleasure to listen to you. And always we get wiser and wiser every time we listen. And people used to think that the CTG is just a trace and you just have to see just one pattern. It's not so, as you have kind of elaborated, it's about the numbers, the small boxes which we have to see, and of course the uterine contraction which comes in. And one of the, I think the important part is when we were getting trained, Dr. Farooq is always to tell them whenever there's a CTG, you go put your hand on the pulse of the mother to see what's the heart rate of the mother and what's the CTG coming on. If they're kind of correlating, then you need to kind of reevaluate and use it. Dr. Ravina empirically said about AI, but I think AI is going to be there, but it's going to take some time because there's a lot of other dynamics. It's not only the trace which going to define the outcome of this, but even with these, when I remember when we were getting trained, there was only one CTG in the whole labor room, apart from not just that is also was only for the first stage. But now the importance of the second stage of CTG is also there, and we need to monitor. And if we can even save one life and one healthy baby, it makes a lot of hell of a difference. So thank you, sir, for keeping us on the toes and wiser and wiser every time. And you are the grandfather of Safog, and it's always a pleasure to see you. And you've been always very kind to all of us. And whenever we requested you, you are always been there with us for all the support. And thank you, Dr. Archana, for inviting us and being there and be part of this program. Thank you very much.
Thank you, Yusuf.
And
So
thank
over
you.
to you, Dipati.
Yeah,
Thank
thank
you so much,
Not
ma'am.
asking questions.
yeah, thank you, Rubina, and thank you, Yusuf. Thank you, Professor Arul. It was really wonderful to listen to Professor Arul and when your inputs as well, Rubina and Yusuf. So thank you very much for joining in. Over to you, Dipti.
Thank you, ma'am. Ma'am, we have two questions in the question answer box. Can we take them?
Yes, please, because I mean, it will be nice to
Yes, ma'am.
really.
Ma'am, so the first question is that kindly suggest drugs till the time we are preparing for interpretation.
Kindly suggest drugs.
Yes, sir.
Yes. Okay, I think the first thing is actually to stop the oxytocin if she has oxytocin on board. The second thing which we recommend is terbutaline or salbutamol, whichever is available. The NICE recommends terbutaline, and we have a lot of experience with terbutaline, which is 0.25 milligram given subcutaneously, or if it is very urgent, you can dilute in 5 milliliter saline and give it very slowly over 5 minutes. But that'll bring the contractions to zero very immediately. The nebulizer terbutaline, which you can use as an inhaler, doesn't work because it gets metabolized in the lung. So that is the advice we give. So in the second stage, when there are decelerations, we have a tendency to ask the mother to push some more and to get her delivered quickly. But we should do the opposite, ask her not to push so the heart rate remains on the baseline for a long time instead of dipping down all the time. If she doesn't push and can control herself, the heart rate when it is normal, it can change the oxygen carbon dioxide balance and she can. So the first thing is ask her not to push, stop the oxytocin, then use the terbutaline, and that'll help. And then you can, once the heart rate has recovered for some time, you can give it for a few minutes and then she can start pushing again. Or in the meantime, you can think of instrumental delivery.
Thank you so much, sir.
Yep.
Yes, ma'am.
You go ahead.
I hope that addresses the query of Dr. Meena Garg. And the second question is by Dr. Shaheen. How to deal with loss of contacts during the second stage CTG? Yes,
I think you have to adjust the transducer. As you know, when the head goes down, usually the shoulder is just above the symphysis pubis. If it is occipito posterior, the chest is right in front, so it can be got on the midline. So the basic tenets of palpation should not be forgotten, whether you have to put it on the right or left side on the iliac fossa just above or in the midline, and you should be able to get the field heart rate. If the ultrasound doesn't pick up, then if you have facilities for scalp electrode, you can use that. Otherwise, the best thing is to use a stethoscope, a pinard, or even a Doptone, because that focuses straight on the heart and that gives you a better reading, and you can see. Essentially, you listen when she's contracting and continue listening even after the contraction. And then you can see how long the heart rate is low. If it is much longer period, it is lower than the baseline, then she needs intervention. So continuous listening is the important thing, not intermittent. All the traditional is we listen every 5 minutes in the second stage or after every other contraction. What if the heart rate is abnormal? With deceleration, we should continue the auscultation continuously to see how long does it come back to the normal. And if it is remaining low for a longer time, then we have to think of intervening.
Thank you so much, respected sir, for being here. It's been a proud privilege to be sharing this platform. And it's been an honor to have this excellent deliberation by you on CTG and for addressing all the queries. Thank you, sir.
Thank you.
Ma'am, with your permission, can we move on to the second session?
Yes, of course, we have to.
So moving on to the second session, I would like to introduce and welcome. It's a pleasure to invite the chairpersons for the second session, Dr. Sadhna Mehta. Ma'am is currently the president of Indore OBGY Society and who has won numerous accolades, including the Limca Book of Records for operating a huge para-ovarian cyst. We welcome you, ma'am. The second chairperson for this session is Dr. Snehlata Dubey, who's currently the secretary of Gwalior OBGY Society and vice president of NMO Gwalior. We welcome you, ma'am. And the third chairperson for the session is Dr. Pradnya Harshe, president of My Parent Society, Jabalpur OBGY Society, and director at Harshe Hospital. Thank you for being here, ma'am. And may I please request Dr. Sadhna Mehta, ma'am, to introduce the speaker for the session, Dr. Gaurav Desai.
Yeah, good evening, dear friends. It's really an honor and proud privilege for me to introduce Dr. Gaurav Desai on such an important topic. He is going to speak on laparoscopic management of ovarian cyst in pregnancy. May I have his CV? Yeah. Dr. Gaurav Desai has done MS, FCPS. He has been a MOX Managing Council member, Assistant Secretary, Foxy Journal, Jogi 2020 to 2024, Speaker at Foxy Programs and AICOG, Foxy Rudra Sinha Award for Endoscopy, CS Dawn and Yuva Foxy Award, Faculty at Endoscopy IMAST, Foxy is CEPOG and at many platforms. So he's an expert laparoscopic surgeon and he's going to speak on a very important topic of ovarian cyst during pregnancy, what way you need to manage, what should be done and what are the steps where we need a conservative management, where we need to follow the patients. So over to you, Dr. Gaurav.
Okay, thank you, madam. At the outset, I'd like to thank Archana Basser, madam, for including me in this program and all the dignitaries that are here today. So as the previous speakers and chairperson said, technology has really taken made a big impact in all our lives as far as obstetrics and gynecology is concerned. And laparoscopy is just one of these, but advancements, I think one of the few big advancements is in endoscopy, and this includes those in obstetrics as well. So I was asked to speak on laparoscopic ovarian cystectomy in pregnancy. I say I don't have any disclosures. Frequently we have women who are pregnant with ovarian cysts, and sometimes we have to manage them throughout the 9 months of pregnancy. And eventually at the time of delivery, if we are doing a cesarean section, and follow them up if we haven't intervened before. But managing any pelvic pathology in a pregnant patient is actually a dilemma for the obstetrician as well as the patient, because the patient frequently asks, what do I do with this cyst? And it's always bothering her throughout those 9 months. So one of the dilemmas is what to do. And if one has to diagnose or have to evaluate it, which diagnostic modality should one use, and which and the therapeutic procedure. If it is done, when should it be done? And will it pose any harmful effects for the mother as well as the fetus? So the underlying principle now in a lot of the endoscopy, I'm talking from an endoscopy and surgeon's point of view, is earlier diagnosis begets a better prognosis, or as we say, a stitch in time saves 9. And this can't be more true for this particular subject and this particular topic, because in a lot of the times we see that if it is not intervened, there is either the pathology grows or there are challenges and complications that occur even after the pregnancy is over. So a number of causes can cause a pelvic pathology. These can be gynecological, for example, ovarian cysts, as we have discussed today, or they could be non-gynecological. So, for instance, appendicitis. And ultrasound now is considered safe and effective and the standard of evaluation in a pregnant woman. So once the decision to actually operate has been made, one either takes an approach for a laparotomy or via a laparoscopy. And this really depends on how skilled the surgeon is and how comfortable the surgeon is doing sort of tackling this adnexal pathology in pregnancy. So some, of course, are very skilled in endoscopy, but not all surgeons can really do this confidently, especially in the South Asian and Indian region. So anything that can manage this pathology to perfection is what is needed. But of course, I mean, if one is skilled in laparoscopy, then benefits really outweigh the risks. Certain benefits include there's less post-operative pain, there's less post-op ileus, there's decreased hospital stay, the pregnant woman can get back home and return to work. The other advantages of endoscopy and laparoscopy in these pregnant patients in particular is they have less chance of being exposed to narcotics and painkillers post-operatively. So there's a less chance of fetal depression. There are fewer wound complications, wound dehiscence, which can really be worrisome for a pregnant woman who is expecting. There's less post-op maternal hypoventilation and a lower risk of thromboembolic events because she's actually mobilized fairly quickly. Apart from that, one of the main plus points for endoscopists especially, and the reason why endoscopists love to do laparoscopy and not laparotomy, is there's improved visualization. The vision is magnified, and this really helps us tackling ovarian cysts or any other pathology, especially in pregnancy, because as the gestational age increases, the uterus occupies a fairly substantial space in the pelvis and the abdomen. So there is less chance, there is more reason to have a modality which shows you accurately what the pathology is. So there's less uterine manipulation needed. There is, as opposed to say laparotomy, where we are constantly holding and moving the uterus around. As far as timing of the surgery is concerned, so there used to be, at least, for when I was learning, there was a school of thought which said that surgeries have to be done in the second trimester. If the woman presents in the first trimester, we need to delay it for the second trimester. And ideally, maybe between about 24, 28 weeks, that is the time. I mean, or it could be 16 to 24 weeks, some authors said. And to really avoid having a surgery in the first trimester as well as the third trimester. The first trimester, usually the school of thought was that the pregnancy is still not set and hasn't, implanted and, hasn't had that support as it should. And in the third trimester, people said, oh, the uterus is too big. Why do we need to intervene right now? Let's just wait till she delivers. So right now, the school of thought is that all these what I just said are not really supported by good quality evidence. And recent literature has suggested that laparoscopic surgery is safe during any trimester. Uh, okay, next we come to patient positioning. And as far as patient positioning is concerned, the the pregnant patient is actually placed, when she's placed in supine position, the gravid uterus or the pregnant uterus, especially when it's in the second and third trimester, it sort of puts pressure on the IVC, resulting in a decrease in venous return to the heart. So when there is decreased venous return, there's a reduction in the cardiac output, there's maternal hypotension and reduced placental perfusion, which is seen during the surgery and which can have deleterious effects on the pregnancy. So patient placement in a slight left lateral decubitus position will actually shift the uterus off that vena cava, thus preventing all this cascade that occurs. Now, it's easier said than done. I think it depends on also where the pathology lies. So if one can achieve doing a surgery with a slight left tilt, then that is the safest for the pregnancy, for the woman, as well as the fetus. If the abdominal access is compromised in the full decubitus position, using a partial left lateral is ideal. And pregnant patients in their first trimester really don't require this because the uterus is fairly small and manageable in size. So where do I usually place the trocars? Let's come to trocar placement. So safe abdominal access for laparoscopy can be accomplished using either the open technique or the closed or using a Viry's needle, as is done in a non-pregnant state. So the concern for using closed techniques is that there's a potential higher risk of injury to the uterus and other organs. And of course, because the intra-abdominal domain is altered during the second and third trimester, there is shifting of bowel, the omentum. So trocar placement should be altered from the standard configuration to the actual size of the uterus. So palpation of the uterus, seeing where the fundal height is, and adjusting your trocar. There is no real fixed position of the trocar. In the first trimester, if it's 8 or 10 weeks, then doing an umbilical is fine. But I think as the pregnancy goes into the second and third trimester, a supraumbilical primary port is a must. So if the site of initial abdominal access is adjusted, then of course both the Hassan technique and the Viry's needle are effectively used. The initial access via a subcostal approach, using the Palmer's point, is also another technique. Authors have also described placing a VisiPort, which is placing the primary port through vision, or using ultrasound, an imaging technique, to have trocar guided placement. So that actually prevents uterine injury. Now coming to insufflation, in case of laparoscopy, we usually try and it's actually a double-edged sword. You don't want to insufflate too much because that will cause undue pressure on the uterus. Anyway, is putting pressure on the vascular structures posteriorly. This adds to that. So we try to keep it as less as possible, but we also don't want to reduce it to such an extent where we cannot visualize the pathology and cannot manage the cyst or any other pelvic pathology in pregnancy, because anyway, the vision is already compromised because of the large gravid uterus. So pressures of 15 millimeters of mercury have also been used safely, and they haven't been shown to have any adverse outcomes as far as literature is concerned. The other aspect of insufflation is that you are insufflating carbon dioxide gas, which occurs during this insufflation and potentially can have these deleterious effects to the fetus uh, and the mother. So, of course, animal studies have demonstrated fetal acidosis with associated tachycardia, hypercapnia, but there is no real data in case of humans as far as CO2 pneumoperitoneum is concerned. However, it is recommended that we monitor the EtCO2 or the end tidal carbon dioxide, and or for instance, capnography is a less invasive approach that ideally should be done to make sure that both the mother and the fetus are safe during a laparoscopy. Next, we come to the point about thromboprophylaxis. And as you all will know, pregnancy is a hypercoagulable state. There is a very small risk of deep vein thrombosis and pulmonary embolism. And having a complex procedure like laparoscopy during pregnancy, we all know that the ergonomic ceiling is much less because laparoscopy is a complex procedure with multiple variables taking place at the same time. But doing this in pregnancy is you're actually managing two lives during this surgery. So one has to be extra careful, and one has to really use an insufflation pressure of as little as possible to achieve the goal. So although there is little research now on the prophylaxis for DVT in pregnant patients, we don't routinely do it for a laparoscopy if it's usually quick, within about half an hour, 1 hour. These things go off uneventful. I personally don't use thromboprophylaxis routinely, unless, of course, the pregnant woman is grossly overweight, is obese, and there are, with a past history or a family history of requiring these drugs. So there's no real data regarding the use of unfractionated or low molecular weight heparin for the prophylaxis. And in patients who require the anticoagulation during pregnancy, the recommended drug is unfractionated heparin, which is proven safe. Now, when we come to adnexal masses, these are there in roughly about 2% of pregnancies. Sometimes they might be really small and need to be monitored. But any sign of any abnormal sign requires some sort of intervention when it grows rapidly, if it has solid areas, for instance. So these warrant an intervention or at least more investigation. Rates of malignancy are usually reported to be between 2 and 6%. And concerns over the malignant potential have already led to the removal of these masses if they persist after 16 weeks. So otherwise, one, as I said before, one does a close observation of these patients with tumor markers and with ultrasound. Now we come to adnexal torsion, which is definitely a risk factor in a case of adnexal masses, especially large ones, in case of dermoid cysts, for instance, which can actually tort around the pedicle. And laparoscopy is recommended both from a diagnostic point of view as well as from a treatment point of view. So about 10 to 15% of these adnexal masses undergo torsion. And multiple case reports and multiple literature has suggested that laparoscopy is safe and effective for an adnexal mass in pregnancy. So if diagnosed before actual death of the tissue occurs on tissue necrosis, then adnexal torsion can simply be managed by a detorsion. One has to, of course, look at the ovarian pedicle and, of course, remove the cyst. But in case of any gangrene or any necrosis that occurs, one might have to actually remove that ovary subsequently. Now, in case of, say, for those who don't want to intervene and, in case this torsion is not managed on time, then this can lead to certain complications like peritonitis, even abortion, preterm delivery, and death. So gangrenous adnexa should be completely resected. Progesterone is the method of support if it is, especially if it is less than 12 weeks. Now, laparotomy may be necessary, depends on the clinical condition in case of when complications occur. With regards to fetal monitoring, the recommendation is that it's not, I mean, there's no intra-op fetal rate abnormalities which have occurred. So really monitoring it before and after is usually done in practice is what I do. And apart from that, we also come to tocolytic use. We usually do cover with progesterone as well as say isoxsuprine or any tocolytic. But threatened preterm labor is successfully managed, but really should be individualized, and it depends on patients if they have previous, risk preterm delivery or any mishaps in their prior pregnancies, and literature reports actually don't really routinely support or routine prophylactic tocolytics. So now coming to two cases, the last two cases are managed with pregnancy with an ovarian cyst. This was a gravida 2, para 1 living 1, a previous LSCS who came at about 13 to 14 weeks gestational age. She had a left adnexal dermoid cyst and was complaining of persistent pain. So she had no other medical or surgical history. On the ultrasound, we found a 9 by 5.5 by 8 centimeter cyst with solid components. And we did the ovarian markers, which were within normal limits. So we we decided to do a laparoscopy, and on placing the optical, placing the camera, we found that there were some adhesions as suspected because she had previous LSCS. So we removed these with the bipolar and scissor and found a cyst on the left side, a large dermoid cyst, as seen on the ultrasound, and also the ventrofixed uterus, which was there. So that sort of helped us in a way because the uterus was in one position and didn't require any manipulation. We used a simple scissors and bipolar to dissect this dermoid out. And we also placed in an endo bag, just an indigenous endo bag through one of the ports, removed that entire dermoid, and then removed the endo bag with the dermoid in situ. So all in all, the patient has progressed well and then delivered a child at term. The second case was a bit of a dilemma because she was a gravida 3, para 2, and 2 neonatal deaths. So she had previous vaginal deliveries. She had 1 neonatal death at about 7 months, and she came at about 17 to 18 weeks with the ultrasound showing a right ovarian complex cyst. She had no real major medical or surgical history, and she was on progesterone as well as aspirin because she had 2 previous mishaps. The ultrasound showed a 10 by 9 centimeter complex ovarian cyst on the right side. And her ovarian markers were a bit of a dilemma because CA125 was high, it was 700. CA99 was 50, LDH was 214. They all were elevated, so we were actually a dilemma whether, some of it is partly because of she's pregnant or is it just the cyst in itself. So we still decided to put a scope in. We were ready to actually do a laparotomy if we found the cyst looking suspicious. So we placed a scope in. This is actually quite, it's above the umbilicus. So the optical trocar is placed supraumbilically midway between the xiphisternum and the umbilicus. As you can see, the left ovary was absolutely fine, and this was a right adnexal pathology. So we had the omentums loosely stuck, so we removed that. And we placed in an endo bag. Unfortunately, I don't have that video of this, but the endo bag, once we we entered that cyst, we found it was absolutely clear. We still sent it for frozen section at that time, and the frozen report said it was absolutely benign. So this was good luck for the patient. And as you can see, the cystectomy was done and the normal ovarian tissue left behind. So to conclude, managing these ovarian cysts or any adnexal pathology for that matter is a dilemma not only for the patient, but even for the obstetrician and the laparoscopic surgeon. So having a good team approach in these cases really helps. And these patients do really well. Both of these patients carried their pregnancy to term. Even the two neonatal death ones actually delivered a live pregnancy this time. And all what I mentioned before are certain guidelines. These are provided by organizations in endoscopy and have to be followed to have a high probability of successful outcome. And all I can say is, laparoscopy, the benefits really outweigh the risks. And I think more and more should be done to benefit obstetric patients. Thank you.
Thank you, Dr. Gaurav, for that excellent talk. And I would like to request our chairpersons, Dr. Snehalata and Dr. Pradnya Harshe, to give their inputs and comments, and then we will take a couple of questions which I can see in the chat box. Dr. Pradnya Harshe, ma'am.
Congratulations, Dr. Gaurav. It was a very wonderful presentation, especially the second case when you are saying that you had a dilemma and the patient delivered. It was good for both of you. And take-home message was very good that it can be done in either of the trimesters. So in all, a wonderful presentation, and thank you so much, Dipti and Archana Basir ma'am, for including us in this super academic feast.
Thank you, madam.
Thank you, ma'am. Snehalata ma'am, would you like to give any remarks?
Thank you, Dr. Gaurav. I would like to say a few words for him. He's an excellent laparoscopic surgeon. I have seen his cases. And I would like to ask you one question. What was the diagnosis when LDH levels and everything were raised, CA125? Was that a malignant cyst or that was something else?
No, this was actually turned out to be a cystadenoma. It was benign. There was no malignant. We sent a frozen at that time itself. We were ready to convert her and do an actual staging laparotomy for this patient. But fortunately for her, it was benign, and she subsequently delivered. So.
And how many big sizes have you removed the cyst during? What was the biggest size you have removed during pregnancy, the ovarian cyst?
So these can range done up to 17 or 18 centimeters. These are fairly large, but the larger the cysts, the chances of them being benign are more. It's smaller ones, the ones that are stuck. Those are ones which are suspicious. Those are malignant.
Yes.
They have projections. They are the surface is rough.
The vascularity is also more.
Yeah, so those are the ones. That's why, I mean, ideally I put a scope and just see what the consistency of that is. And in this case, it was of course cystic. It wasn't really has a lot of solid component. But to diagnose malignancy, these are the points.
Okay. And supposing in a case of a dermoid cyst, if you are excising it laparoscopically, and accidentally it bursts, and the contents all spill into the peritoneal cavity, what do you do in that? Lavage and what else?
I have never really come across chemical peritonitis. It's quite rare. But yes, a copious lavage is very effective. I don't think one should be worried about spillage, but yes, for me, I've always put in the endo bag and opened that cyst above that endo bag. So even if it spills into that endo bag. I think that is one thing I would recommend doing.
And you take it out through some 10 millimeter port, because we are also using endo bags for removing the ovarian cyst or whatever, some structures. So
one option is, of course, one option is removing. If the contents are sucked out, then one can even take it out through a 5 millimeter port. But yes, if they are fairly solid and chunky, then ideally I put a hysteroscope from one of the 5 millimeter ports and take it out to the 10 millimeter.
Okay, okay. Thank you.
And thank you so much, ma'am. Thanks, Dr. Gaurav. We have a couple of questions, in fact, 3-4 questions in the chat box. I think we'll take them quickly. So Dr. Shaheen wants to know what is the preferred procedure for gangrenous appearance of a ovarian torsion, cystectomy or detwisting?
So I would, ideally detwist it and just see if the color returns. If it starts becoming whitish, then it's not a problem. One has to be patient and not try to do too much at one time because people try to intervene very quickly, but one may have to wait for 15, 20 minutes or even up to half an hour to actually see whether it returns back to normal. So you can leave it. One has to follow it up and see, but even if you have to take it out, a good progesterone support, I think, should be fine. Remember, the other ovary is there, but it only creates a problem when it's in the first trimester because that corpus luteum actually supports the pregnancy in the first trimester.
Okay. And the second question again from Dr. Shaheen is which tumor markers to be used in pregnancy with a ovarian cyst, and is there a difference in the upper range cutoff?
Yeah, that's so, I think it's individualized. I think each patient, it depends on the gestational age. For instance, CA-125 levels fluctuate even in trimesters. So one has to actually look at, there's no one particular number, but one has to take the entire picture into account, the imaging, the patient history, the type of, what are you suspecting at the marker levels, but the entire picture has to be taken, not just one aspect of this ovarian cyst in isolation.
Okay. And the next two questions I'm going to club because they both relate to entry point. So Dr. Ramya Lakshmi wants to know, is Palmer's point to be preferred in all second trimester cases? And Dr. Valarmati wants to know if you can quickly brief on port placement for second trimester cystectomy.
Yeah. So, ideally, I mean, obviously, one would ideally prefer intervening as soon as possible. But if you have patients who don't register and who come to you in the second trimester, then now in both these cases, I didn't do a Palmer's point. I went with a direct Broca entry, which was supraumbilical. Primarily,
I think some connection issue.
Yes,
Probably.
I think Dr. Gaurav is having some connection issue. So can we take the...
Yes, ma'am. Maybe we can have him type the
We can have
response.
it later on.
Yes, ma'am. Over to you for the third session, ma'am.
Okay, thank you, Deepti. So we are moving towards our third talk by none other than Dr. Archana Basir, ma'am. And for that, we are having chairpersons, Dr. Jagrati Kiran, Dr. Sunita Madhwani, and Dr. Jigyasa. Can I have CV? Yeah. So Dr. Jagrati Kiran is very able president of Sagar OBGY Society, and she is associate professor at Bundelkhand Medical College. And under her able leadership, Sagar Society had won so many awards like Dr. Durusha Award, Dr. Tanksar Award, and winners of all 4 national awards in 2017. And she had several publications and invited faculty in many conferences. So we welcome you, Dr. Jagrati. Next chairperson, Dr. Sunita Madhwani, dear friend of ours. She is President Ratlam OBGY Society, and along with her OBGY, she is having MBA in hospital and healthcare. She is NABH assessor, and she's having many more credentials to her credit. We welcome you, Dr. Sunita.
Thank you, ma'am.
Next next person is Dr. Jigyasa. Dr. Jigyasa is secretary of Jabalpur OBGY Society, and she had been to many posts in Jabalpur OBGY Society, editor of JOGS 21 to 23, and joint secretary, and she had publications in national and international journals and many chapters in books, and member of many associations. So we welcome you, Dr. Jigyasa. So now I invite chairpersons to invite our speaker.
A very good evening. Yeah. A very good evening to all the dignitaries, friends on this dais. At the onset, I would like to thank Dr. Archana Basir ma'am and Dr. Brajbala Tiwari ma'am for taking me as a part of this beautiful webinar on technologies in obs and gynae. It is my privilege to be introducing the speaker, none other than Dr. Archana Basir ma'am, who is also the convener of this webinar. And can I have the slide, please? Dr. Archana Basir ma'am, she's MS DNB, FRCOG, FICOG, consultant obstetrician and a gynecologist at Akash Hospital, Indore. She is a Guinness World Record holder who has removed largest uterine fibroid. She has been Vice President FOXY 2020. She has been Organizing Secretary of AICOG 2021 at Indore. She was Fellow Representative of AICC RCOG West Zone, Imaging Science Committee Chair, CEPOG. She was Chairperson of FOXY Imaging Science Committee 2015 to 2017, Organized Secretary of ISAR 2016. She was Managing Committee Member ISAR 2018 to 20, IAGE 2018 to 19, and ICOG 2017 to 19. She would be talking on screening of preeclampsia in first trimester, prediction and prevention. I'll just hand over to ma'am now.
Thank you, Dr. Sunita, for your kind introduction.
I would like to welcome you on your own dais.
May I be allowed to share my screen, please? Yeah, at the outset, let me thank my co-convener, Dr. Brajbala, and MOC, Dr. Dipti, for really putting in program in sequence and manage very well. So my best of luck to both of them in their future endeavors, and best of luck to Gaurav as well, because he is also going for some commitments, endoscopy committee chair. And thanks to all the faculties who have joined in as chairpersons, as a speaker, guest of honor, and chief guest. And my special thank to Dr. Sita for collaborating with SAFOG and her committee. So what I'm going to be talking is screening for preeclampsia in first trimester, prediction and prevention. So let's look at how why we are worried about the preeclampsia, because it's a major cause of maternal and perinatal morbidity and mortality. And in India, incidence of preeclampsia was found to be 10.3%, and incidence of eclampsia is 1.9% of all the pregnancies. And globally, preeclampsia is associated with 80,000 maternal and more than 5 lakhs infant deaths annually. That means if we have 26 million deliveries per year, we are dealing with 27,000 cases of preeclampsia and 4,94,000 of eclampsia every year. So preeclampsia screening in first trimester by optimizing available tools, that is technology which we have. So the early prediction of later pregnancy adverse outcomes permits the initiation of management strategies that may prevent or mitigate these complications. So what we have in armamentarium at 11 to 13 weeks of pregnancy, you can detect preeclampsia and predict preeclampsia by history, age, color, parity, hypertension, diabetes, mother had hypertension, IVF conception, biophysical and biochemical markers in 12th week of pregnancy. And markers are deviating from normal in those likely to get preeclampsia. Greater is deviation, earlier you get preeclampsia. Reduce risk of preeclampsia by about 10% by giving aspirin in this high risk group. So these are the bar charts showing you like if you combine only history and you combine history and biochemical markers and sonography, so all technologies used together, your detection rate goes high for predicting preeclampsia. What do we have in evidence? Evidence suggests there are two types of preeclampsia. One is the early onset preeclampsia. There's a higher incidence of adverse outcome. It requires delivery before 34 weeks, that is premature deliveries. Long-term complication to newborn are FGR, and to mother, diabetes and cardiovascular diseases are more prominent consequences. Abnormal placental development is strongly associated with early onset preeclampsia, and in late onset preeclampsia, it requires delivery at or after 34 weeks, and it reflects maternal microvascular disease or maternal genetic composition. Pathology of preeclamptic toxemia, if you see, it is two-stage disorder. Stage 1, there is a placental disorder, early onset preeclamptic toxemia and IUGR, organ dysfunction, and second, stage 2 is maternal response, term PET, which is a milder form. The defective trophoblast invasion and in the uterine spiral arterioles remodeling in the first trimester leads to the reduced uteroplacental perfusion, and there is an imbalance in the biomarkers, especially the SFLT1 and placental growth factor that is involved in preeclampsia pathogenesis. The SFLT1 to PLGF ratio is increased in pregnant women before the onset of preeclampsia. So hence, there has been a surge to reduce preterm preeclampsia. There has been a significant reduction of preterm preeclampsia is possible with treatment started before 16 weeks if you give 100 to 150 milligram of aspirin. So can we identify women likely to develop preterm preeclampsia? Yes, by offering screening at 12 to 13 weeks. It is going to be a challenge which can be turned into an opportunity. So, why we are looking into the first trimester screening? Because if you look, I was preparing for one of my talk, and when I was going through the different literatures and different data, what I found that over 1 in 7 Indian women don't receive antenatal care. And the reason for that are different reasons. If you see here, men did not think it is necessary, it is too costly, I had children before, and there is no one else available to work for them, and they don't know like what's happening in the pregnancy with the checkups. So women are less likely to look for health care, and they come to consultation after passing many hurdles. So with constant resources in the coming time, this problem is going to be more acute. So if you look at the looking glasses, what will be new normal? If you are looking at new normal, because women are very busy, they are working also, they don't want to attend too many antenatal visits, and even some women, because of the constant of resources, want to attend less antenatal visits. So what can we do? So there was a significant points in the development of antenatal care and fetal medicine, and what Professor Kipros Nicolaides has proposed is a reverse turning the pyramid of antenatal care. And traditional prenatal care, which was established in 1929, women would come at 16 weeks of pregnancy. After the 4th month, they would come to visit. Then they would be called every 2 weekly and then every 1 weekly. By this time, majority of would have had problems already started. So what he proposed, that call the women at 12 weeks, do a scan, do your biochemical markers, and the women who require special care should be called frequently, and the women, those who are not, they are at low risk, just call them at 20 weeks, 37 weeks, and then maybe 40, 41 weeks. So what are the nice guidelines, risk factors, pointers in history for preeclampsia? Take a good history. I mean, that's a very, very important thing. Whatever technology we have, but history taking still remains a very important thing. High risk, one risk factor or more, like history of previous preeclampsia, chronic hypertension, diabetes, renal disease, autoimmune disease, multifetal gestation, and moderate risk is nulliparity, obesity, age more than 35, personal history, and IVF. So these are the risk pointers in history. Once you have these risk pointers in history, then take the mean arterial pressure by instrument. Just use your automated machine calibrated to pregnancy. Cuff size should be right. Use appropriate size cuff. Position is sitting back, supported legs uncrossed, at least 2 readings in each arm, and average of 4 readings divided by 3. That's what gives you mean arterial pressure. Mean arterial blood pressure is a potential predictive tool for preeclampsia in a cohort of healthy nulliparous pregnant women. This is a study which is published. Then there is another study, first trimester mean arterial blood pressure and the risk of preeclampsia, the Great Obstetrics Syndrome study, which concluded first trimester mean arterial pressure is a strong predictor of gestational hypertension and preeclampsia in nulliparous women. You can predict preeclampsia by biochemical markers, do a PEPE, pregnancy-associated plasma protein, which you are anyways using in Down syndrome screening. Levels are low in women who are at risk of preeclampsia, less than 0.4 mom. PLGF, placental growth factor, it's an angiogenic factor and levels are low in preeclampsia. SFLT, soluble FMS like tyrosine kinase can be used in prediction of preeclampsia, and these levels are increased in preeclampsia. So you have biochemical markers to predict preeclampsia. And how does this correlate? If the ratio of SFLT and PLGF is less than 38, the risk is 0.4%. And if the ratio is more than 38, the risk of developing preeclampsia is 20%. And if the ratio is more than 85, the risk of having preeclampsia is 56%. So there is a very beautiful article in New England Journal of Medicine, predictive value of SFLT and PLGF ratio in women with suspected preeclampsia. This is my favorite topic, and that's ultrasound. That's what mainly I'm going to talk about. Ultrasound, uterine artery Doppler will provide quantifiable risk factors, increase PI, lower PEPE, and PLGF. That is going to guide you towards the preeclampsia. How to measure the uterine artery PI? I'm not going to be talking in detail here because that's not in the scope of this talk, because you have to learn it when you are performing your ultrasound or in the setting of the workshops. So it has to be measured between gestational age 11 and 13 weeks and 6 days. And sagittal section of uterus must be obtained, and the cervical canal and internal cervical os to be identified. Pulse wave Doppler should be used with the sampling gate set at 2 millimeter to cover the whole vessel and ensuring that the angle of insonation is less than 30 degree. And when 3 similar consecutive waveforms are obtained, the PI must be measured, and then mean PI of left and right artery to be calculated. And again, there are several articles on this. First trimester uterine artery PI and maternal serum PEPE and PLGF in prediction of preeclampsia and primary gravida. This was published in our JOGI in 2018. Can we prevent preeclampsia by aspirin prescription? Yes. Low dose aspirin has been found to reduce the risk of early preeclampsia, intrauterine growth restriction, and preterm birth by improving disordered placentation. Dose is 100 to 150 milligram. Start at 12 weeks, finish at 36 weeks. Time is bedtime. We should be giving aspirin to identified group of women only to have better compliance. It should not be prescribed to everyone. You have to screen women that she is likely to develop preeclampsia and then only prescribe. This is from ASPIRE trial. Incidence of preterm preeclampsia in patient fulfilling ACOG and NICE criteria according to risk by FMF algorithm. And what it says, in women who are screen positive for preterm preeclampsia by these guidelines, but screen negative by the FMF algorithm, the risk of preterm preeclampsia is reduced to within or below background levels. The results provide further evidence to support the personalized risk-based screening method that combines maternal factors and biomarkers. Are there any contraindication for aspirin? Absolute contraindication is history of aspirin allergy, for example, urticaria, known hypersensitivity to NSAID. What are the relative contraindications for aspirin is GI bleed, acid peptic disease, and other sources of GI and genitourinary bleed, and severe hepatic dysfunction. Early detection of preeclampsia, again, by history, by biophysical and biochemical marker. And these are again the detection rate of preeclampsia with false positive rate of 10%. By maternal history, only 50% can be picked up, while with maternal history and mean arterial pressure and uterine artery Doppler 85%, and with maternal history, mean arterial pressure, uterine artery Doppler, and serum biomarkers, 95% is the detection rate of early preeclampsia. So it is a good clinical practice advice. It's been given first trimester screening and prevention of preeclampsia and singleton pregnancy. And Saving Babies Live version 2, a care bundle for reducing perinatal mortality in NHS guidelines, low risk, no risk factor, no other treatment needed. And now do an anomaly scan fetus is more than 10 percentile, routine ANC, symphysiofundal height measurement. If symphysiofundal height measurement is less, then do serial ultrasonography. Moderate risk, assess for placental dysfunction by uterine artery Doppler at 20 weeks. Start the aspirin 150 milligram at night from less than 16 weeks, and serial ultrasonography for fetal growth from 28 weeks onwards. So just to summarize, careful history of previous problems and present pregnancy, have a checklist. Low risk, no need of uterine artery Doppler or biochemical markers, because this is a very frequently asked question. Should we be doing uterine artery Doppler for everyone? So you may not need, just if it's a low risk, then there is no need. Fetal growth at anomaly scan, more than 10 percentile, rest reassured. If other risk factors assess more with uterine artery PI and biochemical markers, start tablet ecosprin in correct dose at night time before 16 weeks in moderate to high risk by history. Later in pregnancy, if BP rises without proteinuria, use SFLT PLGF to assess start of preeclampsia. So just to conclude, preeclampsia can be predicted by taking multiple parameters apart from a good history of past and present pregnancy. What is most important is choose the right investigation for the right patient. And I think the moment of crisis create moments of opportunities. Given the reality that we are in today, we have an obligation to deliver best health care to women of our country in spite of the constraints, so that history remember us as people who acted and not just stood idle by. So thank you very much. Better is possible. It does not take genius, it takes diligence, and it takes moral clarity, it takes ingenuity, and above all, it takes a willingness to try. So use technology for best of your women services you provide to them. Thank you very much.
Thank you, ma'am. It was excellent talk. I request Dr. Snehalata ma'am to conclude. Dr. Snehalata ma'am, is she there? So, Dr. Sunita ma'am, can you? Dr. Snehalata
such a
ma'am is not
beautiful-
here. Dr. Jagrati Kiran ma'am.
No, she's not there, ma'am.
Uh-huh.
It was such a beautiful presentation,
So,
ma'am. Yeah, it was such a beautiful presentation, ma'am. At the onset, I'd like to congratulate you for the way you took the people from the topic of the lecture was technology in obs and gynae, and you never talked about technology unless you emphasized on the importance of history taking and the basic mean arterial pressure. And that is, I mean, technology can never be replacing the basic modality, that is the history taking and the mean arterial pressure. And you beautifully and very simply elaborated all the facts related to prediction and prevention of preeclampsia, ma'am. Thank you very much.
There is one question in chat box. Madam, can we have? It's that if preeclampsia develops, then to stop ecosprin or to continue. It's the question in chat box.
Say it again, Brijwala, I couldn't get the question.
If one develops preeclampsia, then to continue ecosprin or to stop it? It is by Dr. Richa Pragya.
If the patient develops
Has to be
preeclampsia, you
continued.
already started ecosprin, or your patient is not on ecosprin?
Patient is on ecosprin, then to stop or to continue? It is the question.
I think you will continue ecosprin. What I understand from it, that I mean, this we are also facing, because you do start ecosprin, but not every woman you are starting ecosprin is not going to have preeclampsia. What I'm saying, that you start ecosprin, only 10%, will be reduced. Not everyone. So many women will have ecosprin, but still they'll develop preeclampsia. So I'm sure she's asking this, that if the patient is on ecosprin and get preeclampsia, should you be stopping the ecosprin? Right? I'm correct in understanding. I don't think you have to stop the ecosprin. You have to rather add some antihypertensive. You will continue with the ecosprin.
Thank you so much, ma'am.
I agree with that as
And
well.
there is always a dilemma about using 75 microgram or a milligram or 150 milligram of ecosprin, and 100 milligram right now is not available in the market.
We start with 100 milligram only. So I think
Okay.
175 milligram tablet and then they can half because some is going to be lost. So she's in between 100 and 150 milligram.
Okay. So like you take 1.5 tablet rather
Yeah,
than taking that 175 milligram. Okay.
So thank you. So now I hand over mic to Dr. Deepti Gupta for further next session, please. Dr.
Thank
Deepti,
you so much, ma'am. Thank you, ma'am. Moving on to the fourth session for today's evening. And I would like to welcome our dear chairpersons for this session, Dr. Jyoti Banglowala, ma'am. Can I have the CVs, please? Jyoti Banglowala, ma'am, is currently the chairperson of Ethics and Medical Legal Committee, FOXY, and she's a senior gynecologist practicing in Indore who's been a medical legal advisor, vice president of Indore OBGY Society, held various posts, and received multiple awards, including MS Signature, Wonder Foxian, Nari Shakti, Dhira, and invited as faculty in a lot of national and international conferences. Welcome, dear Jyoti, ma'am.
Thank you.
The second chairperson for the session is Dr. Anita Srivastav, ma'am. Ma'am is currently the president of Bhopal OBGY Society, and she was the organizing chairperson of the VP Con that we all attended a couple of days back. She's been the gold medalist and university topper, received Pfizer medallion in medicine, and she's held various posts in Bhopal OBGY Society, senior consultant at Chirayu Hospital, with special interest in high-risk pregnancy and cosmetic gynecology. We welcome Anita, ma'am. And the third chairperson for the session is Dr. Vandana Gupta, ma'am, who's currently the president of Katni OBGY Society and director at Om Shanti Maternity Hospital. She's also an active member of IMA and AGOIN, and her areas of interest are HPV vaccination and cervical cancer screening. We welcome Vandana, ma'am, and I request Jyoti, ma'am, to please introduce and welcome the speaker for the session.
Thank you, Deepti, for the kind introduction. And first of all, I want to congratulate the SAFOG and our chairperson, Dr. Sita Ramamurthy Pal. And thanks to our FOXY leadership, Dr. Jaideep Tank and Dr. Madhuri Patel, and the SAFOG president, Dr. Shyam Desai, our VP, Dr. Nirja Patla madam, our chairperson, Dr. Sita Ramamurthy madam, and Dr. Archana Basir madam and Dr. Brajbala, who invited for this excellent webinar. Thank you, Dr. Brajbala and Dr. Basir madam. And Deepti, as usual, always a very, very hard working girl who coordinated very well this webinar. So thankful to you all for this excellent webinar. As Sunita rightly said, technology, nothing can beat the human skills. Whenever actually what we need skills to obtain the technology also. If we are not skillful, we are not knowing anything, that technology is also not the useful thing for us all. So besides the technology, the doctor must know all the things about the patient, the history taking, the examination part, and then comprehensive study about the history taking, and then the examination, and then what technology has to be used. Otherwise, you are having all the things and you are not knowing how to use. And this is a very interesting lecture by Dr. Sita Ramamurthy Pal on the biochemical interpretation and counseling and everything. So it is actually, I'm fortunate to introduce one of very good chairperson, Dr. Sita Ramamurthy Pal, who is consultant in fetal medicine and obstetrics in the Apollo Multispecialty Hospital and Ankuran IVF and Fetal Medicine Center and Institute of Fetal Medicine, Kolkata. She is the honorary treasurer of Bengal Obstetrics Society for the year 2023 to 24, and she is currently the chairperson of Genetics and Fetal Medicine Committee, FOXY, for the year 2023 to 25. She is the president of Society of Fetal Medicine Kolkata chapter and the 2024 to 26, and she is the fellow representative of AICC RCOG Eastern Zone and joint secretary ISOPAP Kolkata chapter. She is examined RCOG part 3, part 2 and 3. And you actually, this is actually short CV, I think, Sita.
No.
You are having so many other things in your kitty. I invite you for your most.
Thank you so much, Dr. Jyoti, my good friend, my fellow co-chairperson. It's nice to get in touch again. We recently met at the Bhopal conference, and firstly, thank you to Dr. Archana Basir, madam, for coordinating with the Genetics and Fetal Medicine Committee for such an important topic that we are dealing with in our day-to-day practice of obstetrics, where technology actually drives the way, and we need to know how best to use this technology, and that's what we are here for. So thank you, madam. Thank you to the leadership, Dr. Shyam Desai, sir, and our FOXY leadership, Dr. Jaideep Tang sir and Dr. Madhuri Patel madam and Dr. Neerja Bhatla and all the others were here, the chairpersons, and Dr. Deepti, good to connect with you again. And so I'll just share my screen. Today I'm going to be talking on, yeah, this is the one. So can you see that? I'll make it slides. Can you see this? Sorry, I'll just go back. Yeah, can you see this, my slides?
Yes, ma'am.
Thank you so much. Thank you. Right. So we are going to be talking about biochemical markers and what is the interpretation and counseling that we can do. So this is me for you, and thank you once again for the opportunity and for coordinating with our committee. So basically, when we talk about screening in pregnancy, the biochemical markers are usually in terms of what I would say is mainly for of choices where we're trying to use novel biomarkers for other things as well. So these are in addition to what we already had. So they're not like used only in as an isolated test to detect, but mainly whenever we do screening in pregnancy, it is mainly to identify the group of women who are at risk of a particular condition, so that we screen those women who are at high risk and reduce unnecessary interventions and unnecessary invasive procedures when you're looking at aneuploidy screening. And of course, we can help the couple to plan. Our obstetrician can ourselves plan how to best to deal with this pregnancy and where should she be delivering and stuff. And all this will obviously in the long run would help in reducing health costs to some extent, so that we can do the best for the couple and the child. So when sensitivity you define as the basic, so when you look at screening test parameters, we know we look at certain things of a test to give us the best in terms of detecting that disease. So obviously sensitivity is the ability of the test to detect all those with the disease, and specificity is to detect all those without the disease. So when you do any test, there is always a chance that you might, some women who are actually do not have the disease might come screen positive, and you might, falsely call them, falsely detect them as to be screen positive, or, might need to undergo unnecessary interventions. And this is what is a false positive, where they have the number of individuals without the disease and have a positive screening test. So whatever tests we do, whatever, these biomarkers are added, it is mainly to reduce the number of false positives, so that we can increase the sensitivity of a particular test and make it more, make it have the best detection rate. Some other terminologies we also need to know when you talk of biomarkers, especially when we're talking in terms of aneuploidy screening. When we talk, we look at a set of numbers, and most of the times which commonly features this, like in this set, the most commonly featured number is 6. So 6 would be the sort of median here. So generally, when we look at a population, like if this is what a marker should be, then what is the normal range, or this is what is expected to be in the maximum number of people would be the median. So anything more than 2 standard deviations or less than 2 standard deviations would be abnormal for that particular marker. So this is how we look at the multiples of median. So because when you interpret these biomarkers, it is important to understand this median or multiples of median, because when you explain to them that you don't fall in the average category, your biomarker for this particular disease is actually more than 2 standard deviations, of which is more than what would be expected for the age of for your fetus, and that is why it is abnormal. And so that is where your counseling also will begin. So anywhere you have a biochemical marker, it is important to interpret it, understand it, and then so your counseling also becomes easy, and not just see that the test is positive and you go ahead and do an invasive. So you also need to understand what the biochemical markers are, what do each individual biochemical markers mean, and why are they coming positive for that particular disease we are detecting. So multiple of medians is basically a data transform. It is statistical calculation, and the observed patient value is divided by the median value for normal pregnancies at that particular gestational age. So statistically, if you see, if the patient's free beta HCG is 80 and the median for that gestational age is 40, the patient's mom is around 2. So which is, if you categorize 1 as normal, this is this is actually within 2 standard deviations, but it is slightly above the normal. So when a patient comes to you with a particular, for any screening, or especially for aneuploidy, I'm talking about, because most of the biochemical markers that have come out are for aneuploidy. So when she comes in, she has a risk of a baby with aneuploidy. Every woman has a risk. So that is age dependent. We no longer use age as the only criteria, because it can skew your results. But that also influences the risk that the mother has. So that becomes the a priori risk. And then you have different patients markers you use, whether you use ultrasound markers or you use biochemical markers, all that will add to the a priori risk, and you will get something like a likelihood ratio. That is, what is the probability of this fetus being abnormal for this particular lady with that particular age, in that gestational age, and with this biochemical marker. So putting all this together, we get a likelihood ratio. That is, what is the probability of this child having a problem. So obviously, when a patient comes to you, she doesn't understand all this. What she wants to know is, madam, is am I going to develop, is my baby going to have Down syndrome, or am I going to develop preeclampsia, or, so they want answers. They don't understand these figures. So, and that is why it is important for us to understand and then counsel them accordingly. Now, again, a sort of thing which we can understand, that is this fetal aneuploidy. If you're actually screening with biochemical markers and ultrasound, the risk of fetal aneuploidy reduces with gestational age. So if a lady comes at around 12 weeks, her risk of, at the age of 35, her risk is 250, but it reduces to 350 at term. Similarly, the risk of, at 12 weeks is 70, but it reduces to 100 at term. So which means that if a lady has missed her aneuploidy screening in the first trimester, she by chance comes in the second or third trimester, by law of natural selection, itself, chances of this baby having aneuploidy is less, because it has survived that part and has come to this gestational age. So that is what is another way of counseling when you look for these markers. Now, why do we screen for Down syndrome? Because it is still, out of all these aneuploidies, we screen for Down syndrome. That is the most common, because it is still, though it is said to increase with age, 70% of these babies are born to women under 35 years of age. So, as I said earlier, when we talk to a patient, she wants to know what my risks of having this baby with an abnormal problem or a disease. So that is what is the positive predictive value, or what we call as an odds of being affected with a positive result. So what are the odds? That means if my test comes positive because of a particular biomarker or particular test, what is the odd that or rather, what is the chance that my baby will be affected? So this means that if an OAPR of 1:5 is, which will mean that 1 out of every 5 that do not have the disease for that particular test will have an affected pregnancy. So normally when we say that the biochemical, the risk has come back as 1 in 250, we say out of 250 women, 1 will have the disease, 1 to 240 is not. That's not the case. It is usually for that particular screening test, what is your OAPR, and that is what you need to counsel them accordingly. So when we look at screening, especially for aneuploidy, or for other have ultrasound, because ultrasound is now the stethoscope of obstetrics and gynecology, especially in obstetrics. We no longer, for everything we need an ultrasound to detect further. And of course, we use serum markers, which will be the biochemical markers, depending on which trimester you use. And we can use all these biomarkers to be, screen aneuploidy, growth restriction, even preterm births, no open neural defects, and as we heard Dr. Archana Barsar speaking on preeclampsia. Now, when we talk of these biochemical markers, we must understand that, it is, some of them are expression of the placenta, and some are expression of the fetus. So when we talk about PAP-A and free beta-HCG, they are mainly placental products, but free beta-HCG increases in Downs and PAP-A reduces in Downs and FGR, whereas PLGF decreases in FGR. So these parameters have been used to detect these women who might be at high risk of developing the disease or developing the fetus with a problem. Whereas fetal products, as we typically know, that is the alpha fetoprotein, increases in open neural tube defect, but also increases in growth restriction and decreases in aneuploidy. Whereas unconjugated estriol, which we use it as a second trimester marker, decreases in aneuploidy. So everything is calculated as norm, where normal is 1, and because we use a multitude of markers to make it easier, to make it more effective and sensitive, any one abnormal variable can make the or rather assess which marker has made the screen positive. So typical marker profile of euploid and aneuploid fetuses will be when suppose you do an ultrasound, and again, I am reiterating the fact that the biochemical markers that you use for any sort of disease to be screened should not be used ideally in isolation. They should be combined with especially a good ultrasound, especially for aneuploid. Even for preeclampsia, you need to do the uterine artery Doppler. So it is in combination to use these markers along with the ultrasonographical feature. So if you typically use a normal karyotype fetus, the nuchal translucency, if it is 2, the median free beta HCG would be 1 and the PAPE would be 1. And as we said earlier, the free beta HCG would be 2. For trisomy 21 fetuses and PAPE would be 0.5, whereas in trisomy 18 and 13, you will see all of them are actually reduced because it is the defective placentation also happens here, and this fetus does not synthesize enough of these products and that is visible in the screen. So whenever we use a test, we want to use a test which has a high detection rate, and as I said earlier, a low false positive rate, so that unnecessary interventions are avoided. And we want to know for a particular test, when we use all these biochemical markers, as to what is the positive predictive value, which means, as I said, that what is the odds of being affected and what well, because once you know that this test along with some biochemical markers is negative, that means that there's a very good chance that this baby or this lady will not have the disease or have the condition. So both are equally important. So when we talk about aneuploidy markers in the first trimester, we have the double markers, which have PAPE and free beta HCG. And of course, when we add other biochemical markers like AFP and PLGF, that becomes the enhanced FTS. In second trimester, we have the quadruple test, which has the unconjugated estriol and inhibin, and of course, NIPS. We no longer use the triple test because that has a less than 70% detection rate, and all of them have been standardized to have a 5% false positive rate, and that is where we have put a cutoff of 1 in 250, because if you reduce the cutoff, it might increase the false positive rate. So that is why, as a trade-off, they have put as a 1 in 250 for most of these screening markers. In quadruple, you have these AFP, HCG, unconjugated estriol, and inhibin, where your detection rate is around 75 to 80%. And here, with the other biochemical markers, you use like pentascreen, which is also a first trimester test, that is a hyperglycosylated HCG, PLGF, inhibin, HE, and alpha fetoprotein. The detection rate is quoted to be as high as 97% with a false positive rate of 2.5%. Again, none of these are all screening tests, and that is why there is an element of false positive, there is an element of missing. So these are the different tests that you can use for aneuploidy, combining it with all the multimodal markers like age, and your ultrasound showing, taking the CRL, NT, and then adding all the markers. But as of now, the most commonly that we use for aneuploidy screening is the combined test, where we use the age, CRL, NT, PAPE, and beta HCG. We can add all these additional markers like nasal bone and ductus venosus and everything, but they only marginally increase the sensitivity of these tests. So it is very important to do tests that is possible to be done by the general population. You cannot add on markers and do things which makes it difficult for people to follow. So as of now, the first trimester screening, if it's done well by trained people, is the best test to offer for aneuploidy. Again, these are the sort of efficiency for the screening methods, where you add quadruple and everything. But if you add cell-free DNA, the sensitivity of picking up Down syndrome especially goes on to the range of 99%. So it's very, very good test for trisomy 21 and 18 and 13 to a lesser extent. But it is not a diagnostic test because it still only screens the fetus. It does not actually measure the fetal, assess the fetal DNA. It just compares the method, as I will talk about. So this was a study done by our own country by Professor Suresh and Howard Huckle on using the various biochemical markers for Down syndrome screening, and they did say that if you use the biochemical markers, it has a good detection rate of around 80% for a 5% positive rate, where a cutoff can be used at 150, especially in places where they're not accessible to having an NT, but this would be a less ideal situation. But here's, we must remember when we're looking at these biochemical markers, there are certain maternal conditions, certain, other conditions that are happening which can alter these biochemical markers. So it's important to write all this on the form, because diabetes mellitus, the PAPA reduces, and that can increase your false positive. IVF pregnancy itself can lower the PAPA. If there is a vanishing twin, it is very, very important not to use these biochemical markers for aneuploidy, because the vanished twin, which has a altered marker there, will skew your test and will give you a false positive. Again, if the one of the fetus has been reduced, that will alter. But generally, there is pregnancy bleeding that causes no change. So remember to fill up all your forms properly and make the lab know what is there. And also, if she's having beta-HCG injections, which I hope no longer is used, but a lot of time they can also skew your results. So when you talk of these screening offers, there are typical types of tests where you can integrated, sequential, and contingent. Where integrated, you have to use the first trimester and second trimester, and then you give a final risk. And sequential, we sort of, do stepwise. For the low risk people, we again do a quadruple test and decide. But the most commonly that is used nowadays is the contingent screening, where we divide the screen reports into negative, intermediate, and screen positive. Whatever you do when you have a positive screening test because of a biochemical, because of the markers, please do not terminate the pregnancy. And of course, counsel the patient what needs to be done. Just to give you a few examples. So this lady had a BMI of 30. She was a para 1, and the dating was confirmed. She was referred to 12 weeks because her screen was suggestive of a high risk for trisomy 21. And here, if you could see that the scan was done at around 41 CRL, which itself is a wrong way of doing it, because the minimum that you need to have is a 45 CRL. So again, when you're looking at these markers, make sure that this test has been done properly. Look at the images and what these biochemical markers are showing you. So make sure what is the this, and also look at the images, how they are being done. It is still very sad that these may not be using the right standard protocol and interpreting the reports. Here again, this lady had a screen positive, where it said Down syndrome was in positive. The screen was positive, where PAPA was 0.22 mom, and free beta-HCG was 2.16. So again, here you can see the PAPA is actually very low, but again, when you see here, the CRL was only 43.4. So when the minute you see this and you see this, if you have just seen the report, you've not have realized that this was done at the wrong gestational age. So gestational age can change the biochemical marker and give you a false positive report. So make sure you use the final, proper protocol, use the guidelines and interpret it accordingly. So read the report, check parameters, because all results are gestational age dependent, which means that they are CRL dependent. This typically had they said that the biochemical NT was 1 in 250, and biochemical risk was screen negative. And this, but here they had written that the biochemical risk was screen positive, and then the doctor panicked and they said she needs to have an amniocentesis. But actually, overall, if you see purely on biochemical markers, if the test is positive, that has got no significance. You have to combine it with ultrasound-based features, and only then will you get a proper risk. So purely biochemical screen positive is not significant enough. That is what is the significance. Again, this one has an intermediate risk. Of course, for intermediate, we know there are other options, because here the beta-HCG is not too bad. It's slightly high. PAPA is 1.21, and the NT was also fine. So here we need to see what has actually caused the intermediate risk, and then you can give her options of other things like NIPS or a quadruple or a genetic sonography, adequate counseling. So this lady had an, if you can see, this had an intermediate risk. Sorry, it was a screen positive, and she had these markers. But if you have an high risk, ideally you should be offering them a invasive testing. But this is what the Fetal Medicine Foundation follows, that they use other markers and then they divide it further into intermediate risk or high risk, depending on what they find, and then decide whether they need a invasive testing or just routine screening. Quadruple test, if you use, they also have these markers, but it is important to know that if you're using it as a secondary test, never use it like if the patient has already had one first trimester screening, please do not just for the sake of it do a quadruple test. If you're doing it, use it as an integrated test where you're using the first trimester screening, you're doing this quadruple test from the same lab and then giving them a combined result. There is no point in doing two separate first trimester and second trimester quadruple and then interpreting it differently because one might come positive, one might come negative, and you can't ignore the one that is positive. And again, it is going to give you a false positive here. So I'm just going to skip this because of loss of time, but lack of time. But here, basically, she had come up with a high risk. She ideally needed a trial, invasive testing, but went on to have NIPS, which itself came back as high risk. And then when we tested her, it was positive for Down. So NIPS is only a test. Never terminate or decide anything based on the NIPS. You have to confirm it with an invasive test. And so a positive result has to be confirmed. Low risk does not exclude trisomy, and high risk is also not diagnostic. But when you have a structural defect, please do not recommend NIPS because that is not recommended for screening. This lady typically had a very high NT, had all these markers. So in these cases where, as I said, a structural anomaly is there, please do not use the biochemical markers because that is going to skew your results. This lady would ideally need an invasive testing to have a diagnosis whether this fetus has Down syndrome or not, or any other problems, because NT more than 3.5 is above the 99 centile, and that where the risk of chromosomal defects becomes very high. And so they should be offered an invasive testing and ideally a chromosomal microarray. Because increased NT can also be a precursor of cardiovascular defects, skeletal dysplasias, infections, and metabolic disorders. But again, to remember that though increased NT is associated with aneuploidies and other things, most of the babies survive and develop normally. So so when I was talking about odds of having a positive result, here this was long back when this study was done, and they actually predicted as to what is the odds of having a positive test based on these tests. And actually, when you see the first trimester combined test, if it comes back as positive, the odds of 1 in 22, and that is what you need to tell the couple. Or if you're doing a quadruple test, 1 in 32, and triple test, we no longer use that. So this is where we sort of actually counsel them accordingly as to this test has an odds of has an OAPR of 1 in 22, where it is using a quadruple, this has an OAPR of 1 in 32. So biochemical markers are basically, as I said, low PAPA, high AFP, high free beta HCG. We all know PAPA is a large glycosylated protein, and placental growth factor is actually the vascular endothelial factor. So these actually levels decrease in pregnancy with aneuploidies and those with impaired placentation. So here, if you see, they've also been used for screening for SGA and growth restriction. So if normally when you have the biochemical marker, we also say that anything of any PAPA less than 0.4, it is supposed to be sensitive or predictor of SGA. But here they have actually divided, and they said if the PAPA was actually very low, the positive predictive value is to the range of 28% to predict these women having a small for gestational age. So, however, majority have a normal outcome, but they need to have more surveillance. What about beta HCG levels? In fact, there was a study in 2023 which said that extremely high beta HCG levels in first trimester are also risk factors for adverse maternal and fetal outcomes. So either ways, either the beta HCG norm is less than 0.2 or more than 5, they can be regarded as risk factors, and you need to follow up these babies of course, depending on what the final risk has come up, but also for adverse fetal outcomes and maternal outcomes. So this is what we follow in India as to what the intermediate and low risk and high risk, and depending on that we categorize and offer. But what about the serum markers for preeclampsia? As we heard, the famous ASPRE trial, which actually looked at all these markers, and when they said that when you use PAPA, PLGF, uterine artery PI, and the mean arterial pressure, you can predict early onset preeclampsia up to the range of almost 100%, and also late onset preeclampsia. So using all these biochemical markers, FIGO has come up with the guidelines to use this. And when the ladies come back as high risk for more than 1 in 100, you should be ideally starting them on aspirin 150 milligram. When it is not possible to measure biochemical markers, you can do your history and mean arterial pressure, but PAPE can be useful by itself, but they usually use a triple marker where they use a PLGF, PAPE, mean arterial pressure, and uterine artery PI. So this is what is the ASPIRE trial. And what are the new biomarkers that have been evaluated? A lot of them have been evaluated for preeclampsia, especially, as I said, the split PLGF ratio, and in conjunction, again, with USG to predict adverse outcomes in late FGR, because whatever the ASPIRE trial showed, it used the biochemical markers, biomarkers to predict early onset. But again, we do face that is where the SLET PLGF ratio came into and is still actually quite useful. Low serum peptidase inhibitor is also being tried. So this is the pregnancy hypertension group where they look at the SLET PLGF ratio and they start seeing the ratios. If it's less than 38, it is low risk. But if it's more than 85, they are very high risk. And then you sort of monitor them. And sometimes you need to hospitalize them or repeat them if it is between 38 to 85. So that sort of tells you whether this lady is going to develop preeclampsia in the next 1 or 2 weeks, and accordingly you can call her and monitor her. What about the other new biomarkers that have come up? Congo Red is a very good bedside test, urine test, which identifies the misfolded proteins in these women who are bound to develop preeclampsia. And it comes like a urine pregnancy test where you look at the urine sample and you can see whether this lady is going to develop. So that is coming up in a big way. But there are other biomarkers as well, like serum endocrine, placental RNAs, and endothelial RNAs. Basically, as we know, it's all these are in the circulation, and there's a genetic etiology for this. So we are all looking at as to whether this woman is predisposed to develop preeclampsia, and we can find it much earlier rather than later when she already has the disease. Even for diabetes, there have been biomarkers where first trimester insulin, uterine artery PI, along with these first trimester insulin markers can predict. And they have also found that women who are prone to GDM later on, they have reduced first trimester levels of PP13, PAPE, and tumor necrosis factor alpha. But again, these are all in research settings and we have to wait for the space to develop. So any positive screening test depends on the variable that has made it positive. So our duty to the patient is to provide an accurate assessment of risk for any condition that we might be screening using the biochemical markers. And that is why it is important to have adequate pre and post test counseling, because every individual, every parent, the expectations are different, and we are not the ones to decide for them. It is for us to tell them what this is the fact and this is what the probabilities are, and it is for them to decide what they actually what they need to do with the pregnancy. So it needs to be an informed decision, and just don't use arbitrary cutoffs. Look at the markers, look at what they're trying to say, and then you can take a call while counseling them. Thank you so much for your patient hearing. Time.
Thank you, Sita ma'am, for wonderful and very informative talk. It's my privilege to hear you again. I heard you in Jabalpur Rapid Response.
Yes.
So thank you, madam. And I am on the way from to Katni, so I am not visible very clearly. So every obstetrician should know about these biochemical markers in pregnancy. So every obstetrician can explain about these markers, how these markers are associated with aneuploidy and the PET and FGR. And just again, madam, thank you for wonderful presentation.
Thank you so much.
There is one
Sita
question
ma'am, there is
also,
one
actually.
question. Yes. Yes, ma'am. Jyoti, you can.
No, madam. Prajwala, madam, you ask it.
So, ma'am, Sita ma'am, there is one question. And the 30th year, Miss first trimester screening.
Yeah, I saw the screening.
Risk -260. So please.
So it is high risk, basically. So I think when she's already in quadruple, that means she's already 16 to 18 weeks. It is 1 in 60 is a pretty high risk. I would definitely offer an invasive, because NIPS is going to delay it further, and it's again going to be a screening test. So in this point, I would definitely offer an invasive test. Of course, we look at the entire, scan again and make sure they're not missing out any gross abnormalities, because if that is there, then that itself increases chances. But even with this high risk of quadruple, first choice would be to offer an invasive.
Thank you, ma'am, for a very, very clear answer. And
good evening, sir. Good evening, Dr. Keshas.
Thank you, our chairpersons, Dr. Jyoti and Dr. Priya. Now we are moving towards our very, very interesting part of this webinar, and that is the thought by our convener, Dr. Archana Base ma'am, and for interviewing regarding how technology has changed. So for that, we are having Dr. P.K. Shah sir, and sir is well known, and it is not no other person other than Dr. P.K. Shah sir for this part came in mind of madams. And so how technology changed practice, and may I have CV of Dr. P.K. Shah sir? Sir is well-known figure, and sir is past president Foxy, IIG, MOX, FIT, past Dean, Indian College of Medical Ultrasound, past chairman, Imaging Science Committee, past chairperson, ISOPA Waste Zone, and many more credits, credential. And for taking interview, we are having very lovely young obstetrician, Dr. Anshu Basir. And so Dr. Anshu is active member of Foxy Young Talent Committee. She has co-authored the book Ultrasound for Beginners, published papers in national international journals, and she co-authored chapters in Foxy publication as well. So I request Dr. Anshu to please go ahead with interviewing Dr. P.K. Shah sir. Over to you, Dr. Anshu.
Anshu, please unmute yourself.
Thank you so much, ma'am, for the introduction. And I'm really honored to be asking Dr. P.K. Shah all these questions. So, first of all, as you know, we come from a younger generation and we've been exposed to technology since the beginning, really. I would like to ask, sir, what differences has he noticed in his practice with respects to technology when he was at our age and when he started off compared to now?
Well, thank you, Anshu. And I would like to thank Dr. Archana Basir, Dr. Preeclampsia Tiwari, the whole family of Foxy, all charming chairpersons and fantastic speakers. And I would like to wish all the very best to Dr. Gaurav Desai, Dr. Dipti, Dr. Brijbala Tiwari for the election in Foxy. Now, coming to your question, I think I joined as a houseman, and I did my first house was way back in February 77. And the technology and the advances in technology and science has totally changed our lives and has made practice very safe and easier. It is like a metamorphosis, if you really ask me, when I look back at what all facilities we had in 77. The first thing I would like to thank is the availability of computers. Mr. Sam Pitroda, who is known for now a lot of controversies, was the one who was responsible for getting us computers. That has changed very much. The computers and TV are very, very important now in our lives. Number two, when we were residents, we used to get phone call from telephone operator that you are required in labor ward. And we used to have pagers in those days. Now, with the availability of mobile, it has made our lives so simple. And I call mobile that has given us freedom of movement. We can go anywhere and still be available for any emergency or for our unit. Third thing that made the whole total change in our practice was introduction of ultrasonography. I call it as a see-through technology. And the whole thing started with static scanners, A scanners, the B scanners, and then came the real-time ultrasonography, initially with 2D, then came color Doppler, then came 3D, and 4D. And then we have now combination of 3D with R Doppler, elastography, contrast enhanced ultrasound. All these things have added tremendously. And now it is being used for even interventional ultrasonography and availability of interventional radiography. This has totally changed our practice, and I can't think of OBGYN practicing without ultrasonography. And I have a humble request to make that each and every obstetrician and gynecologist must know ultrasonography and should do as far as possible his or her own ultrasound. Second thing that changed was the endoscopy. In 77, I was very lucky that when I was at Cooper Hospital in Mumbai at June, we got a brand new set of Carl stores and we started doing laparoscopy, diagnostic laparoscopy. And I was so lucky that in my first house post itself, I did 18 diagnostic laparoscopies. And then there was no end to it. So when I came to KEM Hospital, the second post onwards, we were going with Dr. V.N. Purandare and other senior gynecologists from KEM for lab TLs at various places like Aurangabad, Jalna, and all so many places. We used to go and do at least 20, 30 lab TLs in my second and third course. Now, initially we had one chip camera and then came 3 chip and now 3D and the whole thing has changed. It is something fabulous that has happened to all of us. But what is important is that the changes that have occurred in practice of infertility, which many of us don't practice, like me, I'm not specifically interested in ART. But when I listen to all the speakers who are doyens of this particular field, I think it's a mind-boggling advances that are happening in ART. Artificial intelligence was discussed earlier on, but I have a feeling that this is going to help us tremendously in medicine and especially in obstetric and gynecology. They look at artificial intelligence, it is so important in predicting preterm labors, incompetent OS, congenital anomalies, especially in first trimester, and what Sita talked about just now. I think all these things are going to be picked up absolutely easily if you have artificial intelligence button in your ultrasound machine. Now, the next thing that I would like to tell you is very important and has changed our practice is the web connectivity. How we got this web connectivity and how we started using it, it was COVID. We must thank COVID for this reason, not for any other reason. Web connectivity has made our life so easier because now today we have joined and we have many people who have joined us, they're listening to us. That is only because of web connectivity. Let me tell you one simple thing is that people who are staying in small villages who are the only gynecologists managing their practice, no partners, no juniors. I think they find it so nice to join webinars and learn things from the places of their work. These are the things that have totally changed the whole way of working. When I was in Cooper Hospital in 77, and now what we see, what is happening around us. So I think if I have left out something untrue, you can add.
No, so that's absolutely correct. Now, I would just like to ask the flip side of it. Do you feel that there is an overuse of technology and the clinical art of assessment of the patient is now being lost, and that the younger generation are relying too much on technology rather than their clinical application?
Very good question. See, because I personally feel that as Indians, we are good clinicians. And not only Indians, I feel everybody from Asia, people are good clinicians. So I think we should not give up. I think people should not do TVS when the patient comes and there is an indication for ultrasonography. first a clinical examination has to be done with per vaginal examination and poroscopic examination. Otherwise, the two fingers will undergo atrophy because we don't use it. So PV has to be done, and we are first clinicians. So that is one thing. And I fully agree that we rely too much on this technology. There has to be a mix of both, clinical acumen as well as the technology. The combination of these two will give you the best results today in our practice. So younger generation should know very well that when they are doing the residency, I think learn from your seniors, clinical evaluation of all the patients. Please don't go for technology right from beginning. It is going to be very harmful in your practice. So be careful. Yes, I agree, Anshu. The younger generation is very computer savvy, mobile savvy, and even latest technology savvy. I think they need to have combination.
So just one last question, sir, regarding your patients. How has the technology affected your patient communication and counseling? Because of course we now have more information, and patients as well have more information. So has that affected how you talk to them as opposed to how you used to?
I think today the patients come to you and they've already looked at the Google.
Yeah, that
I think
Google.
Dr. Google gives them much more information than probably we can give. So we have today, the patients are very smart. So you have to be knowledgeable, first of all, for a particular condition that you are going to talk to and counsel her. But let me tell you one thing, that whether it is a disease that she is having or the problem she has, or pathology she has, or if she has to undergo some operation, you can have all these videos shown to them and counsel them at the same time. That will make them understand very easily. That is number one. Number two, the COVID times told us how to get the reports of the patient on mobile, go through it, and inform the patient on telemedicine. That again was something which we learned, and I think a lot of people are still practicing that. So many times people who are at remote places, but they want to take second opinion. I think this is the best way they can. Yeah, Anshu.
Okay. And sir, one last thing. What technology more do you wish to see in the future to improve our practice? What more? We're already going towards a lot of advancement, but what more do you wish to see in the future?
Let me tell you one thing. That today the time has come when we can have designer babies. Honestly, we can have designer babies. Today the patients ask for it. Unfortunately, we don't do it. But I think a day will come when we will be having baby of couple's choice. Number one. Number two, the artificial intelligence is going to take over in a very big way in OB and GYN practice. Lots of work is being done, and a time will come within a couple of years when artificial intelligence will definitely assist us pick up the diagnosis absolutely 100%. That is the second thing. Third thing is the robotic endoscopy that we have seen now, and it is coming up in a very big way, and I'm sure it will continue. But what I want is robotic ART, reproductive techniques. If that comes, I think there will be a tremendous precision in ART techniques, and we will have better results as far as ART is concerned. But what is important is the best of technologies don't come at a cheaper rate. A lot of money has to be spent to get the best technology. And I wish in future we can have best technology at a cheaper price. I hope God will do this for us. The manufacturers will definitely listen to me, and I hope we will have the best of them.
Thank you so much, sir.
Thank you.
Thank you, Anshu, and thank you, PK Shah, sir. So clearly
I think in the times to come, even cesarean sections will be done laparoscopically. I think maybe we can
I think that is the only thing left with obstetrician. Otherwise, everything will go to the endoscopic surgeons.
No, the
Yes.
problem will is the problem PKs will become redundant, you know.
I agree.
And
No,
so
but
we'll
that
be
is the
doing
only
only
thing, C-section.
we'll be doing only webinars then.
No, but I don't mind. Let me tell you, it is helping a lot of people from all over world, not only our country. And whenever I meet them, they say that we learn a lot from these webinars. So, and let me tell you, today's webinar was a master class. Superb. With Professor Arun Kumar and starting, and Gaurav and Archana and Sita, all of them have done a tremendous job. And I think this is how people should learn. So it was superb. And you don't get everything within 1 or 2 hours. You learn so many things. You don't have time to read. You don't have place. You don't have ways to read. You don't know how to get all this information. So when you get ready-made information within 2 hours time, I think there's nothing like it. So webinars are going to remain. Even if you have physical conferences, we will have to have webinars.
Thank you, sir. It
Thank
was
you so
really
much,
nice
sir.
to hear you, sir, Dr. P.K. Shah, from beginning till artificial intelligence and robotics. I think it was wonderfully you have summarized the technology in obstetrics.
It's because of the technology we are talking to each other and everybody's listening to us.
That is.
Super.
No, and we're definitely more informed as to the diagnosis of the patient, and we can give more efficient treatment with the help of technology. That is most important.
Absolutely.
Yeah. I remember when we were residents, sometime the patient was operated on in a surgical department. They thought it was an ovarian cyst, whereas actually it was a pregnancy over there. So it was that gross a mistake that they made.
Oh.
They thought they'll be able to manage the ovarian cyst on their own.
By the way, Sham is my classmate from KU.
So we've been through the dark ages together.
So it's so nice to see, hear from you, all of you. I have seen both of you working. Sir is a sonologist, and I've seen Dr. Shyam Desai performing vaginal hysterectomy in 15 minutes at Wadia Hospital in those days.
Oh, yeah.
When I was at Wadia's. I've learned a lot from both of you. And to have these two stalwarts of, obs and gynae, I should say, not the national, they are international people here. So it was really, really amazing and very wonderful to have both of you here. So I think we are now going to wind up. And Dipti, are you going to take up?
Very
sir,
well
any-
organized, Archana. Congratulations.
Thank you very much, sir.
Thank you, sir, for
Yeah.
giving
Bala?
opportunity. Thank you so much, sir, for
Okay.
giving
Rasa ultrasound at Science Hospital. He has paved the way for us and given us interest for ultrasound. So there, Dr. P.K. goes a long way for all of us.
Sita, thanks for participating.
Thank you, sir.
Yeah.
Thank you for the
Okay.
opportunity.
Hello, Sita. Yeah. Okay. Bye. Good night.
Bye.
Bye,
Dipti, just
everybody.
propose the vote of thanks.
Yes, ma'am. Yes, ma'am. So
Best
that
wishes to all of
perfectly summed up our webinar, that relationship between technology and science is complex. And we must remember that we have to remain clinicians using technology and not become technicians working in a clinic. So we thank all the esteemed faculty and who participated in this webinar. We extend our heartfelt gratitude to CEFOC President, Guest of Honor, respected Shyam Desai, sir, our chief guests, FOXY President
I
Jaideep
think
Tang, sir,
Dipti-
Secretary General Madhuri Patel, ma'am, and Neerja Bhatla, ma'am. Our speakers for the session, most respected Professor Arul Kumaran, sir, Dr. Gaurav Desai, dear Archana Baser, ma'am, and Sita Ramamurthy, ma'am. Dr. P.K. Shah, sir, and dear Anshu, our esteemed chairpersons, Secretary General CEFOC, Dr. Yusuf, past President CEFOC, Dr. Rubina, ma'am, and the other chairpersons, Sadhna Mehta, ma'am, Snehlata, ma'am, Pradnya Harshe, ma'am, Jagriti, ma'am, Sunita Vadhwani, ma'am, Jigyasa, ma'am, Jyoti Banglowala, ma'am, Anita Srivastav, ma'am, and Vandana Gupta, ma'am. And I'm especially grateful to Baser, ma'am, and Brijbala, ma'am, for this opportunity. I'm really, really honored to have been a part of this webinar in my smallest way possible, and the extent of a gratitude to Team Farmed for the seamless technical support they provided.
Special thanks to Sudeep for really coordinating it so well
Very well.
and doing from flyers to sending the links. So thank you very much, Sudeep. And thank you very much, Farmed.
At the end, I would like to thank PK Shah sir, Baser ma'am, Jyoti, Sita ma'am, Shyam Desai sir for blessings. And I need your support for Environmental Health Committee election. And I'm passionate for working for environment. Thank you so much.
All the best, Dr. Brajwala,
All
Dr.
the best,
Deepti,
Braj.
Dr. Gaurav.
And yes, ma'am, please select me for the quiz committee.
Yes.
All the best.
And even the best of luck to Dr. Sita also.
Oh, thank you.
Yes. Yes.
So,
Thank
uh,
you.
thank you.
Thank you
Bye
so much.
bye.
Thank you,
Thank you.
everyone.
Bye.
Thank you, Sita ma'am.
Thank you.
Excellent talk.
Good night.
Thank you.
Good night, all.
Bye-bye.
Thank you, Baser madam.
Good night, everyone. Thank you.